9點啊，啱10點啊，我哋俾多2分鐘先開始啦。好啦，10點02分啦，大家開始好冇啊？冇人答就當唔反對噶咯喎。HO 係有人答 HO 係表示 NO 打錯咗，定係好咁解啊？嗱，識打中文就打中文啦，其實識打中文都可以打英文嘅。No, let's be serious. So in the coming hour or so, we will go through. We'll do what we originally scheduled to do. Basically, share with you a number of cases, clinical photo or data interpretation related to internal medicine, more related to nephrology. Just as a subspecialty teaching or medical teaching. And after that, if we have time, I may answer some questions and go back to some points that I mentioned and have not, they did not completely resolve on Wednesday when we met online after the medical grad round. So let's go through the cases first. Now, all these will be multiple choice questions, so you are encouraged to give the answer, share your view. If you are, if you do not want the whole class to see your answer, you're very welcome just to send me the answer by a personal message in the chat room. And if you have questions, just type it by all means, and I will try my best to answer. And so the first one, 56-year-old woman, end-stage renal disease due to IgA nephropathy, had kidney transplant 8 years ago and receiving steroid, mycophenolate, and tacrolimus. So present with progressive malaise. And so blood tests obviously showed a very severe anemia with a drastic decline. And platelet is like this, white cell is like this, renal function is normal, MCV, iron profile, B12 folic acid, heptoglobin, are all normal. So which of the following treatment is most likely to be effective? Acyclovir, immunoglobulin, recombinant GCSF, or recombinant erythropoietin? Now, if you can give the answer, or if you do not want to say the answer, you actually can say what is the most likely diagnosis. As long as you are aware of the diagnosis, you will know what treatment would be advisable in these circumstances. 有冇人識係咩嚟㗎？ 見過一次就識㗎啦，呢啲通常都係啦，即係點解要攞出嚟教咧？就係你見過一次，知道啲咁嘅嘢，見過一次就識㗎。So any guess? Now the question is, what is this? Normochromic normocytic anemia with no features of iron deficiency and B12 folate or hemolysis. And isolated red cell, isolated hemoglobin, white cell and creatinine is normal. This is actually a typical presentation of pure red cell aplasia after in patients on a heavy immunosuppression due to parvovirus B19 infection. Now, I'm sure you remember in your pediatric days, parvovirus infection result in a fifth disease, that is fever together with rash, typically malar rash over the cheek, followed by generalized rash. In addition, it can also cause a polyarthritis in children, in pregnant women, cause a hydrops fetalis. In patients with chronic hemolytic anemia or thalassemia, can cause a transient aplastic crisis. But for patients on chronic immunosuppressives, for example, after kidney transplant, they typically cause a pure red cell aplasia, that is isolated failure of the bone marrow to produce red cell. And the treatment is the reduction of immunosuppressive therapy together with immunoglobulin, which normal human immunoglobulin will have some antibody directed against the parvovirus to help the viral clearance. 唔識唔緊要啊，見過一次識就得㗎啦。So isolated progressive decline in hemoglobin with no evidence of deficiency or hemolysis in the background of immunosuppression. The second one, 66-year-old Caucasian man, fever, multiple joint pain, progressive renal impairment, renal arteriogram is like this. So which of the following tests is the most valuable before starting treatment? 有同學答一，有冇同學有其他意見咧 ？PAN yes。有同學答 PAN 係 polyarteritis nodosa。喂，你識個答案點樣可以攞高一分咧？即係你答 PAN 咧，當然攞到分啦。點樣可以攞多一分咧？如果我哋考試問你 What is the most likely diagnosis? You say polyarteritis nodosa, you score the mark. You can score a bonus point by saying classic polyarteritis nodosa. The word classic actually gives you the bonus point. Now this is polyarteritis nodosa with a medium arteries. That is the artery with sizes demonstrable by renal arteriogram showing multiple nodular swelling. These are microaneurysms of the medium-sized arteries, which is the typical appearance of polyarteritis nodosa. And the main renal artery will have this irregular appearance with some nodules, not only atherosclerotic plaque causing narrowing, but actually some part actually bulge out. This is the small aneurysm also at the major arterial wall. This is classic polyarteritis nodosa. And the classical association in a Western country, that is in white population, is associated with hepatitis B. And classic polyarteritis nodosa is arteritis of the medium-sized artery. Unlike the microscopic polyangiitis, which is commonly also labeled as polyarteritis nodosa, microscopic polyangiitis, MPA, is associated with ANCA. Almost all of them have ANCA positive. But for classic polyarteritis nodosa, which affect the medium-sized artery, and may or may not have positive ANCA, but is typically associated with hepatitis B. And in addition to arteriogram, you can obviously make the diagnosis by biopsying the soft tissue rather than the kidney, because biopsying a kidney has a very high risk of bleeding once you puncture the aneurysm. The importance of documenting hepatitis B, first, is because the common association, but second, because the treatment actually requires steroid immunosuppressive therapy and or plasma exchange. And in that case, if the patient is Hep B positive, you have to put the patient on antiviral therapy as a background. So next one. So which of the following treatment is needed for this dialysis patient? 你就咁講咗佢有隻眼有咩abnormality都認得嘅。有冇人認得呢個係咩嚟嘅？ So NSAID, parathyroidectomy, erythropoietin, or intensified dialysis regimen. 有人見到有咩abnormality先？ Calcium deposit over where? this is a typical appearance of conjunctival calcification. Now, unlike other causes, conjunctival calcification, or you can say band keratopathy, as one of you point out, typically present with calcified deposition at the 3 and 9 o'clock of the conjunctiva. That is the margin between the sclera and the conjunctiva. This is an indication of a severe secondary hyperparathyroidism with metastatic calcification. And the other calcium phosphate, high calcium phosphate deposit product can also deposit in other areas, including soft tissue, what we call tumoral calcification, or around the joints. One of the most common joint actually is the shoulder. Conjunctival, as we have discussed, visceral calcification is less common, and the calcification may also be depositing in the arterial wall and renal parenchyma. And the most effective treatment for this is a sign of severe secondary hyperparathyroidism. So the most valuable treatment, most effective treatment would be parathyroidectomy. Intensifying the dialysis regime has some benefit, but the efficacy is very poor. Next one, pre-existing renal impairment, complaint of sudden onset painful blindness of his eye, one eye. Consult private ophthalmologist, 5 days later, admitted for severe acidosis. So what is the most likely cause? I mean, what is the most likely cause of the acidosis? Is it respiratory acidosis, renal tubular acidosis, keto acidosis, or lactic acidosis? 第一件事有冇人認得隻眼係咩事先？即係突然間 sudden onset single eye painful blindness with clouding of the cornea and the sclera. 即係你唔識個答案，唔識個答案都未咩嘅，你可唔可以講下究竟隻眼係咩事？咁由於隻眼係咩事，點解會有 acidosis？ 有冇人認得呢隻眼係咩事啊 ？emergency 嚟嘅喎。雖然咧on the other hand，我哋又真係好似 medicine 係唔會考呢樣嘢嘅，即係隻眼嗰個 diagnosis 係唔會考嘅。Glaucoma, yes, this is acute glaucoma. So what do you think was given by the private ophthalmologist? Now, it's very easy. For anyone, the important learning point actually is for anyone with sudden onset painful blindness of one eye. It is acute glaucoma until proven otherwise. And the classical physical appearance actually is the clouding of the cornea together with the sclera like this patient. And after treatment, what treatment do we give? Yes, we give carbonic anhydrase inhibitor, that is acetazolamide most commonly. And acetazolamide given in a patient with background pre-existing chronic kidney disease would result in severe renal tubular acidosis. It inhibits the proximal renal tubule to reabsorb bicarbonate in essence. So it will result in a drug-induced normal anion gap acidosis. The clinical picture is renal tubular acidosis. Strictly speaking, it is a proximal renal tubular acidosis, but because it is drug-induced, so the patient will not have other clinical manifestation of Fanconi syndrome. We will not have amino acid urea, low uricosuriia, or phosphaturia. So this is acetazolamide. Impair reabsorption of the bicarbonate mainly from the proximal renal tubule. So in the background of chronic renal impairment is a very important and common effect of acetazolamide. And the end result is hyperkalemia, that is normal anion gap metabolic acidosis, hypokalemia because of the diuretic effect, and also dehydration because of the diuretic effect. For your information, acetazolamide is sometimes used also for the treatment or prevention of the altitude sickness, that is mountain sickness, and also used for the treatment of a hypokalemic periodic paralysis, not only acute glaucoma. So next one, 25-year-old woman present with skin rash, multiple joint pain for a few months. While waiting for the result of her investigation, she developed generalized tonic-clonic convulsion. Physical examination show bilateral malar rash. The fundi are shown as below. Which of the following is the most important investigation before starting treatment, not between starting treatment, before starting treatment. Kidney biopsy, anti-double-strand DNA, CSF, or anti-phospholipid antibody. 問你個 funda 認唔認得係咩啫？ Unlike previous questions, this question is a past paper. We actually put this up for final MB as a station 2 case in the past. Cytoid bodies 係 cyst 唔係 cystoid body， 係 cytoid body， 係 CYTOID 啊，大家記得。咁要做咩咧？要做咩 investigation 咧？嗱，考 final MB 我哋問你呢個係咩嚟嘅咧？咁你答 cytoid body 搞掂咗噶啦。咁但係依家條題目唔係講，依家題目問你so there are cytoid bodies before treatment. What additional investigation do you need? What is the most important investigation you need? Now, the important investigation is not to confirm the diagnosis, unlike what you believe, is to exclude the most important differential diagnosis. Now, these are, in essence, microinfarcts, or you can say soft exudates, which is a cottonwool spore, which is a small retinal infarct over both sides of the retina in a patient with systemic lupus. So the most common cause is, most important cause is, most likely cause is a cytoid body. And the difference between this and ordinary cottonwool spore is actually the retina is a bit thickened and elevated, which may not be easily appreciated by fundoscopic examination. But the major differential diagnosis is something we have to exclude. The major differential diagnosis is choroidal tubercle from miliary tuberculosis, which will appear exactly the same in this way. Multiple white dots, slightly elevated, appear to be cottonwool spot over the retina. In someone with fever and fungal and abnormal and generalized tonic-clonic convulsion and multiple retinal white dots. It most like on the background of joint pain and skin rash, most likely it is cytoid body in someone with a cerebral lupus. But the major thing we have to exclude is miliary tuberculosis with obviously tuberculous meningitis. So the most important investigation is CSF for PCR to exclude tuberculosis. Just another important point for you to appreciate is if we consider this is if we are confident that this is cytoid body is in itself an adequate diagnosis of neural involvement of the systemic lupus. Actually, you do not need a seizure, and by the presence of cytoid body, you have to treat the patient as someone with cerebral lupus. That is with steroid together with cytotoxic agent, most commonly cyclophosphamide, unlike nephritis, which we tend to use mycophenolate. For cerebral lupus, cyclophosphamide has a lot more data to prove its efficacy. Next one, 50-year-old man, end-stage renal failure, once again due to IgA nephropathy, kidney transplant 3 months ago, receiving prednisolone, azathioprine, and cyclosporine, and creatinine rose from 80-something to 150 over 1 week. So the renal biopsy is as follows. So what is the most effective treatment of this problem? This is relatively easy. Steroid, increase cyclosporine, decrease cyclosporine, and change azathioprine to mycophenolate.撞都撞到啦，呢個真係。點解有冇同學撞啊？你可以撞下呢個 histology show 到咩？ So these are renal tubules. There are some red cells in between the renal tubules. These are not particularly important. The important abnormality is first, there are quite a number of lymphocytes in the interstitium. And within the renal tubule, in the tubular lumen, these are lymphocytes. Unlike renal tubular cells, which is a large grayish nucleus, these are lymphocytes. These are what we call tubulitis, inflammatory lymphocytic infiltrate into the renal tubular lumen. Together with rupture or partial rupture of the tubular basement membrane, this is a typical appearance of acute cellular rejection. Or acute, nowadays we call it acute T-cell mediated rejection. So the treatment is post-steroid, and if they are not responsive, monoclonal antibody. Unlike acute antibody-mediated rejection, we give IVIG or plasma exchange. So this is lymphocyte infiltrate, tubulitis, and partial rupture of the tubular basement membrane. Acute, in old days we call it acute cellular rejection, or nowadays we call it acute T cell mediated rejection. So next one, 65-year-old man, end-stage renal disease on peritoneal dialysis and a complaint of recurrent low back pain. So which of the following drug treatment would be most likely to be effective? Cinacalcet, teriparatide, atorvastatin, or bisphosphonate? 你識晒呢4隻藥係咩？我都覺得幾好嘅。有冇人認得張 spine 係乜嘢？有冇人知道要用咩 treat？ 撞下啦。點解會同我撞啊 ？D，someone say D， bisphosphonate。嗱，有冇人認得張 spine 係乜嘢先？有冇人認得張 spine 係乜嘢先？嗱 ，the spine obviously show yes. Someone say ruptured Jesse spine. Now the spine, the X-ray actually show a very calcified aorta, which is indirect evidence of a metastatic calcification, as we just discussed. But the more important thing is the spine actually show a preserved this space, but osteosclerosis next to the intervertebral plate, but osteopenia in between. So this is an alternating osteosclerosis and osteopenia. This is ruptured Jesse spine. And once again indicator of a severe hyperparathyroidism, and with a grossly abnormal calcium phosphate balance. The effective treatment will be cinacalcet, which is a calcimimetic direct inhibitor of parathyroid hormone secretion. On the other hand, teriparatide is a parathyroid hormone analog, which is used for the treatment of osteoporosis, and for that reason, obviously, that's not useful. And atorvastatin, I'm sure you know, is a lipid-lowering agent, unrelated. Bisphosphonate, once again, is for the treatment of osteoporosis. And more importantly, bisphosphonate, by and large, is contraindicated in someone with advanced kidney disease because the drug cannot be excreted. So the correct answer is 1, cinacalcet, which is a calcimimetic direct inhibitor of parathyroid hormone secretion. And a drug, in essence, a drug treatment of secondary hyperparathyroidism. It's not a very good long-term treatment because side effect, including hypocalcemia and nausea, is very common. So next one, the patient never noticed any pain over his hands. What is the most likely origin of this disease? Infection, hereditary, autoimmune, or environmental toxic? 有冇人認得呢隻手係咩嚟㗎？有冇人認得呢隻手係咩嚟㗎？有一段時間咧係我哋間唔中喺 Ward 都會見到嘅，呢10年就應該少咗好多。Leprosy, yes. Painless gross resorption of the finger. This is leprosy, and so it is an infective origin, and this, in essence, any gross joint deformity without any pain is a Charcot's arthropathy. This is and leprosy is a specific form not only because it largely involves the hand, but also because it causes a finger resorption. Not only joint deformity, but resorption of the fingers. Actually, Charcot's arthropathy, depending on the site, are related to the etiology. Diabetes typically causes a toes and forefoot problem. Neurosyphilis typically cause knee or hip problem, and syringomyelia typically cause elbow and shoulder problem. So hands with finger resorption, this is leprosy. And although it is an infective origin, the degree of infectivity actually is very low. And if I were you, if you encounter this kind of case in an examination, then you should volunteer to palpate for a palpable ulnar nerve, which typically is present in this case. Next one. 28-year-old woman, 35 gestation, admitted for worsening of ankle edema and hyperpressure. So the renal function is normal, ALP is 130, ALT is much elevated, hemoglobin is lowish, platelet is even lower, white cell is normal, clotting is normal, blood smear show fragmented red cells. So what's the most likely diagnosis? DIC, eclampsia, HELP, or hemolytic uremic syndrome? 我問 most likely 咋，其實以上呢幾個都要諗嘅其實。 三啦，有人答三啦，係啦，唔講邊個啦，有人帶 personal message 咗我答咗三啦，其實就即係三啦。And in essence, help is a specific form of PET. Now, 以上呢四個咧 all these four, three of them are possible. The only one that is that by definition not allowed is eclampsia, which would require a seizure. But this is a specific form of preeclampsia, I mean HELP syndrome, hyperpressure with systemic manifestation, some of them with acute kidney injury, but more importantly, they have features of thrombotic microangiopathy. That's why the blood smear show fragmented red cells. And there are also hemolysis, thrombocytopenia, and also abnormal liver enzyme, and also low platelet count. So this is hemolysis, elevated liver enzyme, low platelet count. So this is HELP syndrome. I must say that the management is not particularly different as compared to someone with ordinary PET. Control the BP, early delivery of the baby is already 35 weeks. The only thing that we have to exclude actually is hemolytic uremic syndrome, which tend to persist after delivery and require specific treatment. BIC is much less likely because of the normal clotting. So next one, 35-year-old chronic intravenous user, intravenous drug user, admitted for ankle edema, serum creatinine 200 something, 3.6 gram proteinuria. So this is the renal biopsy. So what's the most likely cause of the problem? HIV, HBV, HCV, or infective endocarditis? 即係呢四隻已經係涵蓋晒所有 intravenous drug user 會有嘅 infection 咁滯嘅，真係即係我哋關心嘅 infection. So which one is most likely to cause this particular abnormality? I can assure you all these four can cause this pathology, but there is one particularly common. 有人答二，有冇人答其他答案咧？其實四個都得嘅，真係有人答三，有人答二。嗱，其實整蠱嚟嘅，但如果我哋講 worldwide， now this is mesangial capillary glomerulonephritis, and you may not need to know the exact pathology, but if you remember, the normal glomerulus will have a lot of lumens because of the capillaries, and for this one, the lumens are partially obscured because of the swelling of the endothelial cells with splitting of the glomerular basement membrane. This is a mesangial capillary glomerulonephritis. You may notice there are quite a number of pinkish material in this PAS staining glomerulus. These are most likely deposition of the cryoglobulin. So this is a typical appearance of a mesangial capillary glomerulonephritis with endothelial proliferation together with splitting of the glomerular basement membrane. And it can be idiopathic, but in adult, most are due to hepatitis C, and which account for 80% of the cases. And these patients typically has cryoglobulinemia and with systemic features including arthralgia, hepatosplenomegaly, purpura, skin necrosis. But other infections including Hep B, HIV, endocarditis, or other systemic disease can cause a similar appearance. But the most common cause is hepatitis C. 我正話點解話整蠱大家咧？就係the appearance, although worldwide is most of the case is hepatitis C. In Hong Kong, I must say in Hong Kong, and the proportion of, because we have a lot more hepatitis B patient on the background, so in Hong Kong, actually the proportion of cases with this appearance, the proportion of cases with caused by Hep B and Hep C are probably equal. 考試就答 Hep C 啦，因為 Hep C 係 typical 啊嚇。So next one, this one is really a matter of recognition. 75-year Australian man, progressive renal impairment, long history of ankylosing spondylitis. Renal impairment progressive, minimal proteinuria. The CT scan is shown as here. Notice the kidney. So what's the most likely diagnosis of the renal failure? Amyloid, IgA nephropathy, analgesic nephropathy, or allergic interstitial nephritis. And by the way, these four are the classical cause of progressive renal impairment in someone with a background of ankylosing spondylitis. 但係張 CT 係 show 到咩咧？嗱，有人答 amyloid 啦，有冇人揀其他答案？ 嗱，我哋張 CT 見到咩先？大家回心一諗，張 CT 見到乜？咁啊，跟住大家諗下啦 ，amyloid 應該見到乜咧 ？IgA nephropathy 應該見到乜咧 ？analgesic nephropathy 應該見到乜咧 ？allergic interstitial nephropathy allergic interstitial nephritis 應該見到咩？嗱 ，amyloid you should expect actually the kidney will be smooth and diffusely swollen because of the amyloid infiltrate. But for this one, this is irregular shrunken kidney with some hydronephrosis or swelling of the renal pelvis with a bulge here and with minute calcification here or there. So it is irregularly shrunken kidney with medullary calcification and some swelling of the calyx. This is a typical appearance of analgesic nephropathy due to prolonged exposure in terms of years of combined analgesics. Typically is aspirin or NSAID together with paracetamol, commonly together with a caffeine or codeine additive, causing addictive behavior of continually taking the medicine. And these patients will present with a progressive irregular kidney strengthening, progressive renal failure, with a classical complication of renal papillary necrosis. And that's why this is a renal papilla slough off, obstructing the renal pelvis, causing swelling of the renal pelvis. 認得就見過一次就會認得㗎啦。This is not the type of acute renal failure we say after people taking NSAID. This is a chronic form due to use of combined analgesics of multiple components. Because the combination of paracetamol together with NSAID or aspirin will aggravate a long-term renal damage, causing a shrunken kidney. The disease is particularly common in Australia because the combined analgesic is particularly commonly used in that country. Next one, 42-year-old man, malaise, ankle swelling for 2 months, long history of recurring gouty attack and hypertension, and the blood test show low albumin, renal failure, high uric acid level, urine albumin, and the urinalysis is a clear sediment, proteinuria very minimal, bilateral small kidney by ultrasound. So which of the following problems should be considered or excluded? Lead, cadmium, boric acid, melamine. 見過一次就識㗎啦，呢個又係即係見過一次知有樣咁嘅嘢就會記得㗎啦。其實即係 progressive renal failure, hypertension, gout, clear urine sediment, minimal proteinuria。咁嘅 picture 係咩咧？即係咁嘅賣相係咩咧？即係有冇人見過一次就噏到嗰樣嘢嘅？有冇其他同學撞下？1 and 2 cause ATN？ 喂，嗱，理論上1同2都可以 cause ATN 嘅，但係其實 ATN 好少嘅，因為你 ATN 係 acute 㗎嘛 ，acute lead exposure will cause neurotoxicity，acute cadmium exposure cause diffuse injury with a kidney and lung, if I remember correctly. This is lead. This is chronic lead exposure, not acute. Acute will cause acute tubular dysfunction, slightly more common than acute tubular necrosis, together with arthralgia, hemolysis, or abdominal pain and neurological manifestation. This is acute lead poisoning, commonly happened in children. We are talking about chronic lead poisoning, resulting in, I repeat, hypertension, recurrent gouty attack, progressive renal impairment, and the most important point towards this problem is the urine sediment will be clear, what we call band urinary sediment, together with minimal proteinuria. This is a typical appearance of chronic lead poisoning. We call it the gout, the Szeto gout with progressive renal impairment. There may be other manifestations, for example, peripheral neuropathy and the neuropsychiatric manifestation, but the most common manifestation is progressive renal impairment together with a refractory gouty arthritis. This is somehow particularly common in Taiwan. We do not know why. The next one, 42-year-old Indonesian male, nephrotic syndrome, renal biopsy show membranous nephropathy. So which of the following problems should be excluded? 即係睇下塊面先。Scleroderma, tertiary syphilis, mercury poisoning, mycosis fungoides. 冇人認得佢塊面係咩事先？ Is it vitiligo？ 嗱，有人問係咪 vitiligo 啊？咁你 by definition 梗係 vitiligo 啦 ，patchy depigmentation lesion of the skin, you can call it vitiligo. The whole problem is what is the cause of these depigmented skin patches? Typically 都係印尼喎，即係菲律賓有好少人有喎，真係。嗱，有幾位同學就答 mycosis fungoides 啊。This is mercury poisoning. Mercury poisoning. Now, mercury obviously can be inhaled or ingested, but a common form of mercury poisoning in this part of the world is a topical mercury. Because it could be absorbed via the skin. Topical mercury is commonly used from illicit product for skin beauty, 因為有美白作用嘅。Because the mercury actually is a toxin to melanocyte, and therefore a topical application of a very low dose of mercury actually will cause the skin to appear to be whiter and appear to be more beauty. But the absorption of the mercury to the systemic will have systemic effect, causing acute exposure will cause oliguric ATN, but chronic exposure will cause membranous nephropathy or proximal renal tubular dysfunction, depending on the molecular form of mercury that we use. Topical mercury typically will cause a membranous nephropathy. Systemic oral administration, the product typically cause a proximal renal tubular dysfunction. 有少少唔同，我哋都唔係好知點解。But the important point is particularly common in Indonesia, someone with a membranous nephropathy with multiple hypopigmented patches over the skin, consider mercury poisoning. This one 呢條真係 past paper 嚟嘅，我哋出過考試嘅。45-year-old man collapsed in the street, unremarkable past health, but a strong family history of renal failure. Which of the following physical signs is the most likely to be present? 你記得張風大咩先啦嚇？axillary freckles, absence of patella, bilateral hearing loss, or bilateral palatable kidney. 嗱，呢4個 sign 都係有 family history of renal failure 係會有機會出現嘅，代表4種唔同嘅 disease。其實就係依家問你呢4種 disease 邊一種係會咁嘅啫。多數人都答4啦，呢個都 bilateral palatable kidney 啦。This is autosomal dominant polycystic kidney disease with sudden collapse, presumably due to subarachnoid hemorrhage. This is a hemorrhage in the subretinal area, what we call subhyaloid hemorrhage, because the blood is collected in the beneath the hyaloid membrane. This is actually a fundoscopic sign of subarachnoid hemorrhage. So the presence of this would indicate a subarachnoid hemorrhage. A blood with fluid level, and the fluid is some kind of a diluted blood. This is subhyaloid hemorrhage, which is typical of a typical appearance of a subarachnoid hemorrhage. Clinically, they have a meningism. 我哋講翻呢幾個 sign 係咩啦 ？Axillary freckle is present in neurofibromatosis, and some of them may have tuberous sclerosis as well. And but majority is neurofibromatosis. Absence of patella is a nail patella syndrome. Bilateral hearing loss, I'm sure you know, is Alport syndrome. But for subhyaloid hemorrhage and subarachnoid hemorrhage, it is autosomal dominant polycystic kidney disease. Next one, 29-year-old man, mental retardation, brought to emergency department after drinking 500 ml of hand sanitizer solution and then become comatose. So blood test like this, notice the chloride level, liver, clotting, normal. Blood gas is like this, notice the bicarbonate, notice the base excess. And lactate is like this. And which of the following abnormalities is most likely to be present? Pseudo-pneumomediastinum, ketone body in the urine, oxalate crystals, or bitter almond smell from the mouth. 其實係問你知唔知飲咗 hand sanitizer solution， 即係你啲嗰啲酒精搓手液飲完會點嘅啫。即係你而家 hand sanitizer solution 就係酒精搓手液嚟嘅。有人答3啊，有人答3啊，有冇其他答案啊？答3你即係驗翻佢有 oxalate crystal in the urine， 咁你即係驗翻佢係 ethylene glycol poisoning 嚟嘅啫喎。呢個有咩唔符合 ethylene glycol poisoning 咧？有人答2啦。呢個點解唔係 ethylene glycol poisoning 咧？因為佢冇 acidosis 嘅。ethylene glycol poisoning 當然有 oxalate 啦。理論上 hand sanitizer solution 咧可以有 ethylene glycol 嘅。咁啊，但係如果你係 ethylene glycol poisoning 咧，就一定會係 metabolic acidosis 啊。hand sanitizer 咧就係主要我哋日常買到咧就係 a combination of ethanol and isopropanol and the disease due to ingestion of isopropanol is ketosis without acidosis because isopropanol is metabolized to become acetone, which is not an acid but as ketone. So it's a fruity order in the fruity order in the smell and with an acetone in the blood, and there's no acidosis but a lot of ketone body in the urine. And because acetone is a mild sedative, so ketosis will result in a mental impairment. Oxalate crystal 唔得啦，因為冇 acidosis 啦。Bitter almond smell from the mouth. For those who are interested in detective fiction, bitter almond smell from the mouth is the typical sign of a cyanide poisoning. Hand sanitizer solution will not have cyanide. Pneumomediastinum is a sign of esophageal perforation due to ingestion of corrosive, not hand sanitizer. 即係你飲強水咧就會 pneumomediastinum 啦，飲洗手液咧係唔會 pneumomediastinum 嘅，條食道係唔會穿嘅。即係等於你飲李斯德林攞口水咧，條食道都係唔會穿嘅。Next one, 66-year-old man, end-stage kidney disease on peritoneal dialysis for 3 years, presenting with awake abdominal discomfort. Ultrafiltration from dialysis is satisfactory. Abdominal X-ray is shown here. What is the most appropriate action? And observation, give laxative, choker manipulation of the catheter, or surgical repositioning of the catheter. 有冇人撞下咧？應該點做咧？肚痛，但係冇話出唔到水喎。你睇下條喉點樣？嗱，大家當然留意到啦，條喉飛咗去一邊啦。But manipulation of the catheter is not necessary as long as the outflow from the PD is okay. This is important for when you become a host officer. If the patient has abdominal pain but without any fluid drainage problem, that is ultrafiltration problem, it doesn't really matter where the catheter is. And if you do a regular screening of abdominal X-ray for PD patients, very often the catheter is not in the correct place. As long as the outflow is okay, it is okay. This patient, you can infer the abdominal pain to be due to constipation. You can see a lot of fecal loading in the abdomen. So the correct management actually is to give oral laxative rather than manipulating the catheter. 嗱，如果你答1咧，其實我係接受嘅。你話 observation 即係唔關事嘅，冇嘢咁，其實可以接受嘅。當然比 laxative 會好啲啦。This one obviously has a lot of feces in the abdomen. But the more important thing is there's no need to work on the catheter as long as fluid can come out. So next one, 56-year-old man, advanced CKD, long-term hemodialysis is planned. 6 weeks after the creation of left forearm AV fistula, complaint of persistent numbness of the left hand, this one. Examination revealed good radial and ulnar pulse, warm periphery, no ischemic change, but loss of prefix sensation of all fingers of the left hand. So what's the most likely diagnosis? Carpal tunnel, dialysis SS still, radial nerve damage, AV fistula stenosis. 又係見過一次就識嘅，成隻手痹晒咁， 做就喺洗腎個人隻手度。Ischemic mononeuropathy， 哇咁 specific 嘅，真係識答 ischemic monomelic neuropathy。This is ischemic due to the inadequate blood supply after to the nerve after creation of the AV fistula, and as a result, it only happened in the only in the AV fistula hand. The alternative pattern is a diastasis still, which is a ischemic change affecting all the tissue of the hand. So there will be a substantial amount of a soft tissue atrophy. So this one is mainly numbness. There's no soft tissue atrophy in the tissue. So this is a ischemic monomelic neuropathy. Or you can just say ischemic neuropathy would be completely adequate. For your purpose, actually, as long as you know this is some kind of neuropathy due to the AVSS, that would be good enough. 有同學好眼利啦，就睇到啦，呢度有一個好細嘅 ulcer 嘅，係啦，同埋呢度都有個好細嘅 ulcer 嘅，所以係有啲 ischemia 添嘅。66-year-old woman, one CKD long-term PD is planned. After 10 cuff catheter insertion attempt of peritoneal flushing, noted poor PD outflow, worsening dyspnea, chest X-ray show is like this. So which of the following tests is the most important in order to plan the management? CD4X, CD peritoneogram, pro-fluid glucose level, pro-fluid D-lactate level. 喂，注意我嘅問題係咧 ，most important to plan the management， 唔係 most important for diagnosis 喎。有冇同學講其他？有同學答 PD pro-fluid glucose level 咧。如果你想 confirm 個 diagnosis 咧，但 I suppose most of you know this is pro-peritoneal complication, or in the old days we call pro-peritoneal fistula because of the congenital defect in the right hemidiaphragm, causing leakage of the PD fluid into the pro cavity. And to confirm the diagnosis, you can simply do a pro aspiration and test the glucose level because the PD fluid has a lot of glucose and also a lot of lactate. And the lactate in PD fluid is different from the lactate in our body because in our body it is L-lactate. In the PD fluid, it's a combination of L and D lactate. But to plan the management, even if we prove the diagnosis of a very high PD fluid, pro-fluid glucose level, we need a CT peritoneogram because we want to see where the leak is and then to plan for surgical repair. On the other hand, if we cannot see where the leak is, then the surgeon may have a difficult time to repair the defect. Nowadays, actually, irrespective to the pro-fluid result, we will always perform a CT peritoneogram because pro-fluid glucose level is not 100% reliable. So if the clinical feature is compatible, but the pro-fluid glucose level is not high, we will go for CT peritoneogram to confirm the diagnosis. But if the pro-fluid glucose is high, we still go for CT peritoneogram because we want to locate the site of the defect to plan for surgical repair. Next one, 66-year-old man, end-stage renal disease. 1 week after hemodialysis was started, present with left calf swelling, Doppler ultrasound confirmed deep vein thrombosis. The blood test before anticoagulation started is something like this. Platelet is low, white cell hemoglobin is on low side, white cell is normal. Clotting seems to be normal. PT is marginally elevated only. Actually, it's quite normal. So which of the following investigation is most important? Platelet factor 4 antibody, cardiolipin antibody, ADAMS13 antibody, or serum protein electrophoresis. 有冇人認得呢個係咩事？其實問嚟問去就點解個 platelet 會低嘅 ？HIT. This is a typical time 1 week after starting hemodialysis because of the use of heparin. So we want to do platelet factor 4 antibody. Anti-cardiolipin antibody, you can order it, but it is less likely because it's isolated thrombocytopenia without any prolongation of APTT. ADAM13 is the cause of thrombotic thrombocytopenic purpura. So we expect there will be microangiopathic hemolytic anemia as well. And the patient should also have acute rather than chronic renal failure, and also fever and neurological manifestation typically. So this is a heparin-induced thrombocytopenia, and this is the traditional scoring. We consider the degree of thrombocytopenia, the time of onset typically is 1 week after the first heparin exposure, and whether there is any thrombosis, and whether you have alternative diagnosis to explain the thrombocytopenia. And if you have a high score more than 6, then it should be considered as a HIT. The presence of platelet factor 4 antibody is not necessary, but would be highly useful to confirm the diagnosis, particularly in those cases who are not 100% sure. So we have to use heparin-free dialysis, but may have to use other alternative anticoagulants for the treatment of the deep vein thrombosis. Next one, 68-year-old woman, diabetes, background retinopathy, short generalized abdominal pain. Laboratory result is like this. Sodium on low side, potassium on high side. This bicarbonate is low. Creatinine is high. Osmolarity is, I can say, high. Salicylate level and detectable urine ketone is negative. So what's the most likely cause of the problem? Pancreatitis, metformin, acetazolamide, or ethylene glycol. 呢條就唔係成日出，不過呢種病人就成日見嘅。我哋一年都應該閒閒地都有700、90個㗎啦。有冇同學認得係咩嚟㗎？呢個唔認得就計下 N9 gap 先啦，係咪？好明顯，bicarbonate低啦，咁即係有 acidosis 啦。咁你計下 N9 gap 咧，我哋唔計 potassium 啦，130減96減12，96加12即係108啦。108咁130即係嗰個 N9 gap 係22喎，咁22即係咩咧？22即係 high N9 gap metabolic acidosis 喎。咁salicylate有冇 ketone 有冇 ？So this is lactic acidosis due to metformin. This patient has a background retinopathy, very likely has a background renal impairment undiagnosed, or she may simply have some other cause of acute kidney injury. But if she is taking metformin, irrespective to whether the renal failure is acute or chronic, taking metformin will have a very high risk of developing metformin-induced lactic acidosis, which is type B. Type A is due to tissue hypoxia. Type B lactic acidosis is due to toxin, most commonly metformin. 見嗰次認得 you do not need a pattern recognition here. You just follow the usual diagnostic algorithm. Metabolic acidosis, calculate the N9 gap, and then exclude other causes of high N9 gap metabolic acidosis. Then you actually can also calculate the osmolarity and determine the osmolarity gap. But once you follow the diagnostic algorithm, you will come to the conclusion that this is high N9 gap metabolic acidosis, but this is not due to salicylate, not due to ketone, not due to toxic alcohol. So lactic acidosis would be the very likely cause. Next one. 35-year-old woman, recurrent generalized edema. The edema worse in the afternoon, show only transient improvement with diuretic therapy. The edema was so bad that she could not wear boots or gloves. No diarrhea, no systemic upset, physical examination unremarkable except some edema. No heart failure, urinalysis normal, renal liver thyroid function normal, albumin 38. So what's the most likely cause of the edema? 呢個又係見過一次就識㗎。有同學真係好認真咁問我咧，如果佢咧一條都唔識答以上嗰啲問題咧，係咪有問題咧？咁我可以話俾你聽，以上嗰啲一條都唔識答咧，其實真係冇問題嘅。 呢堂嘅目的就係你見，我就想 show 啲咧，大家都唔係咁常見，但係咧係見過一次就希望大家我見過啦，所以我再見我就會認得。每個人第一次見咧都係應該唔識嘅，即係如果你見第二次都唔識，咁就唔係幾好啦。第一次見係應該唔識，等於呢條第一次見係冇人會冇 Q21，第一次見係我唔相信有人會識喎，真係即係我其實問下在座各位有冇人見過啫喎，真係。因為你未見過就一定唔識嘅，冇可能識嘅。第21條，雖然我可以話俾你聽，第21條咧，我第一次遇到咧就係我做 medical student 讀晒 cardiology 嗰陣時。This is idiopathic edema, periodic, may be genuine, may be perceived weight gain and edema with presumably due to abnormal fluid retention due to sensitivity to estrogen. So it's far more common in female. So it's a weight gain and after exclusion of other systemic disease, and the pathophysiology is not sure, but many of these patients have a concomitant psychological or emotional problem. 唔係 Bartter syndrome 啦 ，Bartter syndrome. If you know nothing about Bartter syndrome, you can consider is a genetic hereditary form of loop diuretic abuse. 咁你就知道會發生咩事啦。So loop diuretic will not result in edema. In fact, they will be hypovolemic. Bartter syndrome 其實就係 fusion 埋嗰個 target mutate 咗啫嘛。So they are just like congenital diuretic abuse. Constrictive pericarditis will cause edema, but they will be progressive rather than intermittent. But more importantly, they will have abnormal physical signs, elevated JVP, pericardial knock, and other things. Primary hyperaldosteronism, most important is hyperpressure without edema. Primary hyperaldosteronism, what we call aldosterone escape. They will not have edema, they will only have hyperpressure. It's only secondary hyperaldosteronism that will result in, that can have edema. Next one, 35-year-old woman present with intermittent painless hematuria, no history of renal stone or lung pain, plasma creatinine calcium bicarbonate level, a normal plain abdominal X-ray is like this. So which of the following are likely to be present? Hexagonal crystal and recurrent urinary tract infection, history of high-dose vitamin C usage, or family history of renal failure in middle age. 嗰陣時有冇人見過呢張 abdominal X-ray 知道係咩嚟嘅啫？即係又係見過一次就認得嘅，即係兩邊 kidney 都好似一撇撇啲 calcification， 咁呢啲係咩嚟㗎？呢啲唔係 stone 嚟喎，你注意。Nephrocalcinosis yes， 咁 nephrocalcinosis 會係咩咧？咁 nephrocalcinosis 好多 cause 啊，咁但係你注意喎，呢個 creatinine 有 normal， calcium 有 normal，so what's the most likely cause of this nephrocalcinosis? Nephrocalcinosis can be due to hyperparathyroidism, can be due to distal renal tube acidosis, can be due to any cause of hypercalcemia. But I remind you, this one, the calcium is normal, renal function is normal, bicarbonate is normal. So essentially exclude all these problems. So if there's no additional electrolyte abnormality, the most common cause of nephrocalcinosis actually is medullary sponge kidney, which is a developmental defect of the renal medulla, resulting in diffuse calcification. And these patients are usually asymptomatic, except they may have a history of recurrent urinary tract infection. And some of them may have recurrent hematuria, and that's all. Their renal function is normal, and they will not have a family history of renal. It is a developmental problem. It is not a hereditary problem. Although if you have a family history of medullary sponge kidney, the chance is slightly higher, but it is not, strictly speaking, a hereditary disease. It is a developmental defect. So there should not be any family history of renal failure. 大家都知 hexagonal crystal in urine 就係 cystinosis 啊， so it's a multiple renal stone in young age, but the stone are radiolucent. Next one, 32-year-old man, progressive hearing loss and renal failure. This is the picture of the right ear. So which of the following physical sign is most likely to be present? Brachial fistula, absence of patella, thrombocytopenia, anterior lenticonus. 你有冇人認得隻耳仔係咩事啫？應該係唔認得嘅，即係溫實經爺真係應該唔認得。嗱，但 anterior lenticonus 好明顯就冇睇幅相啦。老實講 ，hearing loss renal failure 最 common 就 就 Alport syndrome 啦 ，Alport syndrome 就有 anterior lentic conus， 即係第四嘅。但係呢個人隻耳仔唔係咁嘅喎，呢個人隻耳仔係咁嘅喎。嗱，如果係 anterior lentic conus hearing loss due to Alport, you will expect it is a sensory neural deafness. But for this one, it is actually more a conductive type of deafness because of malformation of the middle ear. You notice these flaps, deformity of the external ear. This is 又係見過一次，聽過就算啦。Brachial otorhinal syndrome, a less common form of hereditary syndrome, familial syndrome, genetic syndrome, renal dysplasia, ear deformity, and together with a brachial fistula or any malformation of the neck or the ear. As compared to glomerular disease, is Alport or Fechner. More common is Alport, 就有 anterior lentic conus. I won't go through other hereditary syndrome. 其他啲係真係唔使識噶啦，淨係識 Alport 就夠啦。其實，不過我擺呢個出嚟等大家見過一次，呢個世界上有啲咁嘅嘢嘅，唔係全部龍有 kidney 就係 Alport 嚟噶嘛。Next one, 58-year-old man, end-stage renal disease, long-term hemodialysis, persistent anemia. Hemoglobin is like this. MCV is normal. Platelet white cell is normal. Iron is like this. TIBC is like this. Saturation is there for 16%. Ferritin 660. What is the most appropriate interpretation of the result? Iron overload, iron deficiency, normal iron status, specimen or laboratory error. If you conclude it's iron overload, then you do not give iron, you increase the dose of erythropoietin. If you consider iron deficiency, you replace the iron and look out for blood loss. Laboratory error, you will repeat the test. Normal iron status, then you treat the anemia, probably also by increasing the dose of erythropoietin. 有冇人知道呢個係咩嚟㗎？The important is how to interpret the iron problem. Now, ferritin level in dialysis patient is not reliable because of the chronic inflammation would result in a high ferritin level in many patients. So the most important diagnostic clue would be the iron saturation. And the traditional cutoff is that if the iron saturation is less than 20%, then you can make a diagnosis of iron deficiency. And even though the ferritin may be slightly high, some people call it functional iron deficiency, but in reality, the high ferritin is due to chronic inflammation. This is iron deficiency. And in fact, there is now good evidence to show that for dialysis patients, even they do not meet the traditional criteria of iron deficiency with a saturation less than 20%, iron supplement would be useful to correct anemia and reduce the need of hospitalization and transfusion if the saturation is less than 40%. There are other measures for iron deficiency, but the most valuable one for general use purpose is iron saturation. Less than 20% is diagnostic. Less than 40%, we can already give an iron replacement to improve the response to erythropoietin or to improve the hemoglobin level. I think this is the last one. A 33-year-old man, recurrent renal stone treated with ESWL. Renal function, serum calcium, parathyroid hormone level are normal. CT urogram reveal no structural abnormality. And urine culture is negative. Stone analysis, calcium oxalate, calcium phosphate. So which of the following would be most effective in preventing recurrence? Low protein diet, low calcium diet, hydrochlorothiazide, or oral bicarbonate? 喂，呢條真係考過，呢條係 Final MB MCQ 嚟㗎。有同學答3啦。In essence, what are the medical treatment of prevent recurrent renal stone? Fluid. Now, so in general, we advise a low sodium diet, but a high calcium diet. High calcium diet actually will not increase the risk of stone recurrence. even though the stone is calcium stone, but actually will decrease the risk of stone recurrence because calcium from the diet will actually chelate the oxalate in the gut and therefore reduce oxalate absorption and therefore reduce the chance of calcium oxalate stone recurrence. But for drug, the most effective one is hydrochlorothiazide. Potassium citrate is only valuable if the patient has concomitant acidosis, particularly renal tube acidosis. And other drugs are allopurinol for uric acid stone, obviously, and pyridoxine is only useful for hyperoxaluria hereditary form. But for general use, calcium stone, hydrochlorothiazide, in one hand, it will reduce the urinary calcium excretion and also increase the urine output, and therefore it is the most effective evidence-based treatment to prevent calcium stone recurrence. 嗱，今日就 case 就係咁多啦。有冇同學關於呢啲 case 有咩問題先？我再重複一次，大家唔識係唔緊要嘅，就係即係見過一次咁啊，即係下次見就有少少印象。Since Szeto can 有同學問啦 ，Since Szeto can cause hypokalemia, how can it be used to treat hypokalemic periodic paralysis？ 嗱，其實咧都冇人知嘅，係Szeto係 presumably 咧係令到個 muscle membrane 咧係因為Szeto係 add on 個 carbonic anhydrase 係 presume carbonic anhydrase， 咁咧係 presumably 咧係令到嗰啲skeletal muscle 嗰個 membrane 咧係 stabilize 咗，係冇咁容易係有 intracellular shift of potassium 嘅啫。嗱，我老實講個 molecular mechanism 咧，我都唔知嘅。不過咧就presume 就 add on 佢有 add on muscle 咧，係等啲 calcium 冇咁容易走入個 muscle 度嘅。冇啲 potassium 冇咁容易走入個 muscle 度。有冇其他問題咧？Answer HUS in the presence of 9係 in the presence of is it possible to answer hemolytic uremic syndrome due to the presence of fragmented 唔係嗱，我哋永遠都係啦嗱，如果呢條係 MCQ， 大家注意呢條係 MCQ， 所以個問題係 what is the most likely， 但係永遠呢啲答題目都係問啦 most likely， 唔會話 what is the 嘅，即係 what is the possible， 但係全部都 possible 㗎。eclampsia 係唔 possible 嘅啫 ，eclampsia 因為未抽筋嘛，其他啲都係 possible 㗎。我哋問係 most likely。I fully agree. Hemolytic uremic syndrome is a reasonable diagnosis, but it is not the most likely diagnosis in these circumstances. Because hemolytic uremic syndrome, you will not expect the patient to have a grossly abnormal liver enzyme. 你留意 MCQ 成日都係咁問㗎啦 ，What is the most likely？ 梗係唔會，即係唔係問可唔可以，梗係可以啦。問邊樣最可以啫嘛。即係如果你係考 Y 話，或者我哋係即係 clinical discussion 嗰陣時問你，你答 hemolytic uremic syndrome， 我哋梗係覺得呢個係一個恰當，即係可以接受會俾分嘅答案。MCQ 呢個就唔係會俾分嚟嘅答案，但係 unfortunately。有冇同學有其他問題咧？喂，如果冇咧 ，extra case based is this level difficult of MB examination 啦？有冇多啲啦？但開始已經有啲同學覺得呢啲係比較深啲嘅啦。我特登咧係俾啲深少少嘅大家嘅，因為咧即係淺嗰啲，我相信你而家到年尾啦，你都應該識啦。咁即係當一個 exposure 見過啲深少少嘅嘢，你唔需要識嘅。不過好多呢啲都係你見過一次，你下次見到你會有少印象，咁其實已經好好噶啦。唔識亦都唔緊要嘅，識咗就會高分啲咁解嘅啫。我反而係所以你話俾多堂呢啲咧，我覺得對你考試真係冇乜撞啊！大家真係即係讀啲即係常見啲嘅嘢會好啲。我反而想趁呢個機會咧，講翻兩個 point 係我禮拜三講過，我即時答唔到你，我依家可以答翻你嘅咧，就係一就係關於宿舍嗰度有同學確診啦。咁根據衛生署嘅指引咧，就係除非你係同佢一間房，同嗰個確診者同一間房住， 或者係同佢喺病發之前2日，即係驗到 positive 之內2日之內係同台食過飯嘅。如果唔係咧，都唔當緊密接觸者嘅，咁係可以照樣上 ward 嘅。即係等於大廈都，即係等於你即係住嗰座確診大廈，你座大廈有確診，你唔係同佢同屋冇食過飯，都唔當緊密接觸者咁解啫。咁啊，所以可以上 ward 嘅。咁啊，department 亦都即係知道呢個安排㗎啦。咁啊，第二樣嘢，我哋禮拜3講過嘅咧，就係關於戴 goggle 嗰個啦。咁我其實我嗰日都唔知，我後尾先知道咧，就係嗱，我嗰日講咧就係 HA 咧就冇規定咧，你睇病人咧一定要戴 goggle 嘅。咁咧就不過如果你冇戴而你睇完嗰個病人隔咗1-2日之後確診咗，2日之內確診咗咧，就當你係緊密接觸者㗎啦。咁就有即係所有嘅不幸事件啦。咁就反而咧，原來咧 faculty 咧有明確指引你上嗰見病人咧係要戴 goggle 嘅。咁我係會包括埋咧，就係如果你考翻 OMB 要睇真病人咧係要戴 goggle 嘅。咁就而嗰日有同學問啦，咁啲 goggle 喺邊度嚟咧？咁其實咧呢個禮拜咧開始咧就跟緊 medicine 嗰啲同學咧就應該逐步咧會去 department office 度咧就係攞 goggle 噶啦，咁就係 reusable 嘅。咁就係其實都係 HA 派嗰塊嘢嚟啫，因為都係醫管局提供嘅提供俾我哋嘅。咁就我嘅理解就係，如果呢一所係跟緊 surgery 嘅同學咧，就 surgery 會派嘅。咁就大家考試係我哋預期嘅，其實 faculty 叫你哋係帶埋翻去嘅，即係我記住 HA 嘅指引就你唔係一定需要帶，但係原來 faculty 係叫你帶嘅，咁啊大家記得帶啦。咁啊大家你唔係一定要帶。我哋faculty派俾你嗰個 goggle 嘅，你可以自己買一個勁啲嘅，我自己都有個勁啲嘅，咁就即係不過勁啲嗰啲通常啲霞氣係緊要啲啊，你如果想帶勁啲嗰啲，你就自己試過，唔好乜帶咗乜都睇唔到先。咁啊，第三樣嗰日我初步講咗，但係我都冇講實嘅咧，就係有好多同學好關心咧，就係。嗱，如果你正式考嗰日係唔係確診啦，即係緊密接觸者嚟唔到考試，或者嚟到有少燒，我哋唔俾你考試，咁我哋就會考。我哋依家唔叫 supplementary examination， 我哋就會叫5月中嗰啲叫 additional examination。咁啊就同 final MB 嗰個 year end OSCE 一模一樣嘅，4個 station 一樣咁考嘅。咁啊要考supplement嗰啲一齊考啦。第一次考唔到嘅正式 final MB 考唔到嗰啲又會一齊考，咁就會有翻 grade 攞翻分。咁咧就咁好多同學就會關心咧，就係咁如果嗰次係考完之後會 pull up 要 pull up viva 咁點算咧？咁樣咁我哋就已經 agree 咗咧，就係考完嗰個 additional examination 嘅1-2日之內啦。我哋依家都未講實邊一日就會，因為依家 most likely 咧就會我收到嘅消息就係5月11號會考 additional examination 嘅。咁就跟住應該5月12或者13咧就考，如果要考 pull up viva 就會考 pull up viva， 咁就冇丁 Y 啦。即係我哋最多俾個 A 你嘅啫，但係即係冇辦法啦，就 distinction 就真係做唔到噶啦。咁如果要考嗰一班係考唔到，要考10咧，因為 by university regulation 或者 by faculty regulation 咧，如果你嗰次都係第一次考啫，如果你肥咗而 surgery pass 咗咧，係可以考10嘅。咁就我哋會喺跟住嗰一個禮拜係幫你補考翻嘅。咁但係補考嘅形式就未必係 year end OSCE 嚟噶啦，可能真係帶你上嗰睇 case 嘅。咁啊，我哋都係希望一個靈活嘅做法，係 make sure 應該 pass 到，即係少少一時失手，但係應該 pass 到嘅同學咧，都係準時可以 pass 到做 houseman 嘅啫。咁啊，有冇其他問題？嗱，如果冇咧，我哋今日就到此為止啦。不過我再重新鄭重講多次啊！今日嗰啲 case 咧係即係唔識係唔緊要嘅。我希望大家就見嗰次啊，有啲咁嘅嘢嘅呢個世界上咁就夠噶啦嚇。咁啊，大家俾心機讀書。咁啊，如果完咗呢堂你先至諗到有咩問題嘅，你就寫 email 問我啦。今日就到此為止啦。